Hello, everyone. Welcome to week 9. This week, we're going to talk about analyzing data. Healthcare organizations routinely collect and report data to external entities. They help to assess performance, they identify trends, they drive and are behind all different types of quality improvement in healthcare. We're also going to talk about benchmarking, which is comparing performance against set standards. And this guides organizations in optimizing and improving patient care and efficiency. We'll talk about both internal and external benchmarking, and we'll talk about some national quality programs like the Hospital Value-Based Purchasing Program, and we'll introduce you to dashboards. Dashboards are a quick, convenient way of presenting data and using some data visualizations that you'll see throughout healthcare. Again, here we are with Chapter 9, Benchmarking and Analyzing Externally Reported Data. We'll talk about types of benchmarking. We'll link benchmarking to value-based purchasing programs, a big term in healthcare. And then we'll talk about healthcare report cards. Benchmarking is discussed is comparing performance to standards, but we're looking at these both internally within an organization. So we're looking at typically how we did last year compared to this year, and external benchmarking, how we're doing to other like hospitals. And we do this to identify both strengths and weaknesses, and it's part of the whole quality improvement culture that we are engaged in healthcare. The first step to benchmarking is to identify the issue to be benchmarked. And this could be involving both patient care and non-patient care. It could be wait times. It could be claims denials, right? And we have to locate the internal data related to the issue. In a surgical setting, we might be looking at postoperative complications, returns to the OR, things like that. These are internal data points that are related to the core issue. Thirdly, we analyze the internal data. And after we look at the data internally, we need to look at external data if it's available for benchmarking. And to do that, we collect public domain data or claims data if it's applicable. And then we do a comparison as mentioned in step 6. Hopefully we don't have a performance gap, but every once in a while we do have one where the external organizations are doing better than we are in some way. And then we'll communicate that back. And then we'll break down things and look at action plans, performance level targets, monitor, and hopefully by doing this, we wind up with improvement and then the cycle starts over again. An example of this is the Hospital Value-Based Purchasing Program, and this is from CMS, and it's an example of formal benchmarking. And it includes 4 domains, or areas, if you will. These include process of care, patient outcomes, patient experience, and efficiency of care. And this generates a TPS, or total performance score, that's used to determine if an incentive payment is added to the Medicare inpatient payments for participating hospitals. Now we get into dashboards and scorecards. They're similar, but not the same. They both are methods to indicate performance in key performance indicators, or KPIs. These guide management decisions, and they include a combination of indicators that are measured on a per unit basis for comparability across time. And the categories could be clinical, could be operational, could be financial. Whoops. And here's an example here. We have a geographic variation in Medicare spending. So you could click on a state like Oregon and get state of Oregon level. You could look at it nationally. You could look at inpatient, post-acute hospice, and so on. And Medicare chronic conditions. So you can see here, as we see in most Medicare graphs, the categories on the x-axis, and then the quantity, or in this case, the per capita Medicare spending, is on the y-axis. And this gives us data, not surprisingly, showing that we spend just under $32,000 on Medicare patients per capita with 6 or more chronic conditions. The National Quality Forum provides a framework for endorsing these quality measures, and they have working groups to look at quality improvement efforts in both public and private sectors of healthcare. These National Quality Forum endorses consensus standards for performance improvement and ensures that we have consistent high quality performance information that's publicly available. And in order to get this endorsement, we need to propose a measure, back it with scientific evidence. So you might hear the term clinical based guidelines. We check for validity and reliability of the measure. We look at feasibility and usability, and then we assess the related or competing measures. Other Medicare quality measures you can see are on datamedicare.gov, Hospital Compare, Nursing Home Compare, Physician Compare, Home Health Compare, Dialysis Facility Compare. And these data is provided in online query and comparison. A lot of these you can download into CSV files and then open them up in Excel, look at them, analyze them to your heart's content. Here's an example here. Outpatients having surgery got an antibiotic at the right time within 1 hour of surgery. Higher percentages are better. Of course, this is better because it prevents postoperative infections. And you can see a great deal of difference here between, say, Northwestern Memorial Hospital and Providence Hospital of Chicago, or between Rush University Hospital and Providence, and so on. We've covered risk adjustment in a few things, but this isn't necessarily related to reimbursement in terms of a risk adjusted score or an RAF. This is an adjustment of risk of an adverse outcome. It makes sense that patients who are older and have more comorbidities, are sicker, have a higher risk of complications. So we try to adjust for that. The other thing is we have to adjust for whether it's a teaching hospital with residents and fellows, whether the patients are Medicaid, Medicare, and so on. And so we use this to compare performance to expected performance using the standardized infection rate. So in other words, the observed infection rate that we talked about in HIM 200 divided by the expected, and so on. For all of these standardized rates, a value of greater than 1 is interpreted that the facility's rate is higher than expected given its risk. And then the central line associated bloodstream infections. So this is a CMS measure. This is looking at all the central line associated infections, both observed and expected. These are calculated for each hospital. And the chart to the right talks about lower percentages are better. So you can see the Cleveland Clinic is slightly over 1. So they're not doing as well as they should be compared to University Hospitals of Cleveland or Metro Health. And that's all I have for you. Thank you for watching. Please reach out if you have any questions about this material. Bye now.